What if the most dangerous decision a military doctor could make wasn't acting too boldly but obeying the rules exactly as written? What if the moment that saved thousands of lives began with senior physicians calling a technique madness, reckless, and outright suicidal? In the early years of modern warfare, military medicine was collapsing under its own certainty. Field hospitals were overflowing, surgical tents soaked with blood, and mortality rates climbed so fast that death became statistically expected rather than feared. Soldiers weren't dying only from bullets or shrapnel. They were dying from procedure, from doctrine, from medical rules designed for peacetime bodies, not shattered ones. The manuals were clear: stabilize slowly, avoid aggressive intervention, control infection by minimizing exposure, follow protocol step by step. These rules were treated as sacred, passed down from prestigious academies, and enforced by rigid hierarchies that punished deviation more harshly than failure. In theory, they represented safety. In practice, they were killing men by the thousands. Doctors on the front lines saw it first. Young surgeons, exhausted, hands shaking from days without sleep, watched patients fade not because injuries were unsurvivable, but because treatment came too late. Blood loss, shock, internal trauma, waiting politely for permission to be addressed. The clock was always faster than the rule book. And then someone crossed the line. Not out have arrogance but desperation. In one overcrowded military hospital, under constant bombardment, a small group of doctors began doing the unthinkable. They ignored the sequence. They intervened early. They acted before stabilization. They accepted controlled risk instead of guaranteed death. What they were doing violated everything they had been taught. Senior physicians called it reckless. Administrators called it malpractice. Some even warned it bordered on criminal behavior. But something strange started happening. Patients who should have died didn't. Men with catastrophic injuries survived long enough to be infection declined instead of spreading. Recovery times shortened. The numbers didn't just improve, they contradicted decades of medical certainty. And that terrified the system far more than failure ever had. Because if this worked, it meant the experts were wrong. It meant textbooks were outdated. It meant authority had been mistaken. And it meant thousands of deaths were not inevitable, they were preventable. The reaction was immediate and hostile. Reports were dismissed as anomalies. Results were blamed on luck. Doctors were warned to return to approved procedures or face consequences. The word madness wasn't hyperbole, it was an official label, a way to discredit without debate. But war has a way of stripping ideology bare. As casualty numbers exploded and resources collapsed, commanders began asking a dangerous question. What if the madness was the only thing working? What if survival required breaking rules instead of honoring them? Behind the scenes, the forbidden technique spread quietly, not through conferences or journals, but through whispers between surgeons, through notes scribbled on blood-stained gloves, through desperate conversations at 3 a.m. when another patient was bleeding out and the manual had already failed. Every time it was used, the same pattern emerged. Faster intervention, higher survival, fewer amputations, lives saved that should have been written off. And yet, officially, nothing changed. No acknowledgement, no credit, no admission of error. Because accepting the truth would mean admitting that medicine, authoritative, institutional medicine, had been standing in the way of survival. And this was only the beginning. If this revelation surprised you, take a moment to really think about what it means. Entire medical systems, backed by authority and tradition, can be wrong for years, sometimes decades, while people pay the price with their lives. Understanding how and why that happens is the only way to recognize it when it happens again. If this story is already changing the way you see military medicine, doctrine, or innovation, under pressure, let me know in the comments. Right madness saves lives, so I know you're following closely. And if you want to see more hidden moments where so-called insanity quietly rewrote history, make sure to leave a like and subscribe. That simple action tells the algorithm this kind of deep, uncomfortable history matters. What made this situation even more lethal was incompetence. It was confidence. Military medicine wasn't failing because doctors didn't care or lacked skill. It was failing because it believed, with absolute certainty, that it already knew the correct way to save lives. The traditional medical doctrine of the time was built around order, sequence, and control. Stabilize first, stop bleeding. Delay invasive intervention until the patient is ready. These ideas made sense in clean hospitals with unlimited time, staff, and supplies. But war erased all of that. There was no time, no sterility, no second chance. Yet the protocols didn't adapt. In battlefield conditions, wounded soldiers arrived in waves. Massive blood loss, crushed organs, traumatic shock. The body doesn't wait politely in those moments. It collapses fast. But doctors were trained to slow down, to follow steps, to avoid what they called premature aggression. And every delay compounded the damage. Here's the uncomfortable truth. Many soldiers died not because their wounds were unsurvivable, but because treatment followed an outdated sequence. Bleeding continued while doctors waited for stabilization that never came. Internal injuries worsened while paperwork and hierarchy dictated restraint. Shock deepened while intervention was postponed in the name of caution. At the time, shock itself was misunderstood. It was treated as something to manage, passively keep the patient warm, administer fluids, slowly observe. But in reality, shock was a countdown. Every minute without decisive action increased mortality exponentially. The body was spiraling, and the rules insisted on watching it happen. Even worse, junior doctors knew it. They saw patterns repeating. Same injuries, same delays, same outcomes. But speaking up was dangerous. Military medicine was rigidly hierarchical. Questioning senior physicians wasn't just frowned upon, it could end careers, promotions, assignments, reputations, all depended on obedience. So most stayed silent, and silence became deadly. What really trapped the system was data blindness. Early battlefield statistics were crude and misleading. Survival rates were averaged across massive populations, masking what actually mattered: timing. When aggressive intervention happened early, survival jumped. When it didn't, patients died. But those distinctions were buried under layers of reporting and denial. Here's where the psychology turns darker. Admitting the doctrine was flawed meant admitting responsibility, not just for future deaths but for past ones. That kind of realization is intolerable to institutions. So instead of questioning the system, they blamed variables: severity of wounds, environment, inevitable losses, anything except the rules themselves. Meanwhile, doctors who quietly broke protocols saw something undeniable. Patients stabilized after intervention, not before. Bleeding control created stability. Speed saved lives. Risk, when calculated, was safer than hesitation. This directly contradicted everything written in the manuals. And contradiction is threatening. Every time a patient survived under these forbidden methods, it wasn't just a medical success, it was an accusation. Proof that authority had been wrong. Proof that obedience had a body count. That's why resistance was so fierce. The system wasn't protecting patients anymore. It was protecting itself. What most people never realize is this: innovation in war rarely fails because it doesn't work. It fails because it challenges identity. Doctors didn't just follow procedures. Were those procedures? To abandon them felt like erasing their own legitimacy. So the system doubled down. Official training remained unchanged. Reports were soft. Terminology was manipulated. Successes were labeled exceptions. Failures were called expected. And the forbidden technique remained underground, spreading quietly among those who valued outcomes over approval. But pressure was building. Casualties were increasing. Resources were shrinking. The gap between official doctrine and real survival was becoming impossible to ignore. And soon, the war itself would force a reckoning no committee could delay. Before we move forward, leave a comment with the word timing if you're starting to see how delay not injury was the real killer. The technique itself didn't look revolutionary on paper. There were no new machines, no miracle drugs, no futuristic equipment. That's part of why it terrified the medical establishment. The danger wasn't in complexity, it was in timing and intent. This forbidden approach demanded that doctors act before the patient appeared stable. Instead of waiting for vital signs to normalize, surgeons intervened while the body was still in crisis. Bleeding was controlled immediately. Organs were addressed aggressively. Procedures, once reserved for fully stabilized patients, were performed under conditions that textbooks explicitly warned against. To the establishment, this crossed an ethical line. Medical academies had drilled one principle above all others. First, do no harm. The technique was framed as violating that oath. Critics argued that intervening too early increased the risk of death on the operating table. They warned of catastrophic complications, uncontrolled infections, and legal liability. In official language, the technique was labeled unsafe. In private, it was called insanity. But the battlefield didn't care about ethics committees. The logic behind the technique was brutally simple. A patient in hemorrhagic shock doesn't die because surgery is dangerous. He dies because blood loss and organ failure reach a point of no return. Waiting for stability in those cases wasn't caution, it was surrender. The new approach accepted short-term risk to prevent guaranteed collapse. Here's where the system panicked. If this was true, then decades of teaching were incomplete. Worse, they were misleading. The most shocking part wasn't that the technique worked, it was that the body responded better when doctors stopped waiting for permission to act. Stability followed intervention, not the other way around. This reframed everything. Shock was no longer something to observe. It was something to interrupt. Bleeding wasn't a symptom to monitor. It was an emergency to end immediately. The forbidden technique treated time itself as the enemy, not the injury. Senior physicians rejected this interpretation outright. They demanded randomized trials, peer review, long-term studies, things impossible in the middle of a war. They dismissed frontline results as anecdotal, emotionally driven, statistically insignificant. But the surgeons using the technique weren't chasing theory. They were counting survivors. And the numbers were impossible to ignore. Units that adopted early aggressive intervention saw mortality rates drop dramatically. Amputation rates declined. Infection rates fell because wounds were addressed sooner. Patients reached evacuation points alive instead of dying on stretchers. These weren't marginal gains. They were decisive differences. Still, the technique remained unofficial. Why? Because it threatened the hierarchy more than it threatened safety. Accepting it meant admitting that experience under fire mattered more than institutional authority. That junior doctors on the front lines had discovered something senior experts had missed, and institutions do not forgive that easily. The technique spread the only way it could, through trust. Surgeons taught surgeons quietly. One case at a time. Try this first. Don't wait. If you hesitate, you lose them. There were no manuals, no formal training, just shared survival knowledge passed in whispers. Each successful case added pressure. Each saved life raised an unspoken question. How many had died because this wasn't allowed sooner? That question haunted the system. Instead of embracing the evidence, leadership tried to contain it. They issued warnings, reinforced doctrine, reminded doctors of acceptable risk. Some physicians were reassigned. Others were threatened with disciplinary action. The message was clear. Innovation without permission would not be tolerated. But war doesn't ask for permission. As casualty numbers surged and hospitals buckled under pressure, commanders began prioritizing results over regulations. Quietly, unofficially, the technique started appearing in more units, not because it was approved, but because it worked. And soon the technique would face its ultimate test, not ink theory, not in debauchery, but in a case so extreme that following the rules would guarantee death. Before we go there, comment forbidden. If you're starting to see how Fear Not Science kept this technique in the shadows, the case that changed. Everything arrived without warning. The kind of patient doctors quietly dread because the outcome seems decided before treatment even begins. A soldier brought in at dawn, barely conscious, pulse fading, uniform soaked through with blood and mud, multiple traumatic injuries, massive internal bleeding, severe shock, already setting in by every rule in the book. This man was not a surgical candidate. Standard doctrine was clear. Stabilize first. Restore blood pressure. Warm the body. Wait. But there was nothing left to wait for. His vitals were collapsing faster than fluids could be administered. Every indicator screamed that he would be dead within minutes if nothing changed. The room went silent. Senior doctors hesitated. This was the moment where rules usually took control. Declare the case non-viable. Provide comfort. Preserve resources for patients with better odds. That decision had been made countless times before, quietly, efficiently, and with tragic consistency. But one surgeon spoke up. He had used the forbidden technique before, not officially, not documented, but he had seen it work when nothing else did. He knew the risks. He also knew that following protocol here meant certain death. So he said the words no one expected. We operate now. Immediate resistance followed. This patient won't survive anesthesia. He's not stable. You'll kill him on the table. And the surgeon replied, with a sentence that would later be repeated in hushed tones across multiple units. He's already dying. Waiting won't save him. There was no approval, no formal authorization, just a decision made in seconds. The forbidden technique was initiated. They moved fast. Bleeding was controlled immediately. Organs were addressed without delay. Procedures that manuals insisted must wait were performed under extreme conditions. The operating environment was chaotic, imperfect, risky, everything medical doctrine warned against. And then something happened that shouldn't have. The patient didn't collapse. His vitals stabilized during the intervention. Blood pressure rose. Pulse strengthened. Shock began to reverse. The body responded not with failure, but with resilience. Against every expectation, the patient survived the procedure. Hours later, he was alive. Days later, recovering. Weeks later, evacuated. The room changed after that. No one celebrated. No one spoke loudly, but everyone understood what they had just witnessed. This wasn't luck. It wasn't a miracle. It was proof, and proof is dangerous, because now there was a living contradiction walking around a man who existed only because doctors had broken the rules. His survival quietly dismantled years of accepted medical certainty. Every argument against the technique suddenly sounded hollow, but the response wasn't gratitude. It was fear. Administrators demanded explanations. Reports were rewritten. Language was softened. The case was framed as an anomaly, a one-off, an exception that proved nothing. The surgeon was warned not to repeat the approach without authorization. The technique was still officially unsafe. Yet something had shifted. Other doctors began asking questions. Not publicly, privately. What did you do differently? How early did you intervene? What if we tried it in similar cases? The forbidden technique began spreading not because it was sanctioned, but because survival spoke louder than authority. Soon, similar cases followed. Same pattern, same results. Patients written off under traditional doctrine were surviving under aggressive, early mortality dropped where the technique was used. Where it wasn't, death rates remained unchanged. This created a split reality. Official medicine said one thing. Battlefield reality showed another. And that tension was about to explode, because the more lives were saved, the harder it became to pretend nothing was happening. The system was being exposed, not by failure, but by success. And success, when it threatens hierarchy, is often treated as rebellion. At first, the numbers whispered. Then they started to shout. What made the situation unbearable for the medical establishment wasn't a single miraculous recovery, it was repetition. The forbidden technique didn't save one patient. It saved many, again and again, in different units, under different surgeons, in conditions that should have produced identical failures under traditional doctrine. Mortality rates began to diverge, a way that could no longer be explained away. Units that followed the manual to the letter continued to lose patients at predictable rates. Units where the technique was quietly adopted, so survival climbed sometimes dramatically. Severe trauma cases that once carried near certain death now had measurable chances. The gap widened week by week, and eventually even skeptics noticed. That's when discomfort turned into embarrassment. Senior specialists began reviewing reports and found themselves facing an impossible contradiction. The data was real. The outcomes were documented, yet accepting them meant admitting that years of authority, prestige, and certainty were flawed. Not slightly flawed, fundamentally incomplete. So the response wasn't curiosity. It was defensiveness. Instead of asking why the technique worked, critics focused on who was using it. Inexperienced surgeons, uncontrolled environments, irresponsible risk-taking. The results were reframed as dangerous anomalies rather than evidence. The technique wasn't evaluated, it was attacked. But numbers don't argue. They accumulate. Every life saved under the forbidden approach made the old explanations weaker. Mortality curves didn't lie. Infection rates fell. Shock-related deaths dropped sharply. Amputations decreased because tissue damage was addressed sooner. These were outcomes no amount of rhetoric could erase. Behind closed doors, some senior doctors began to panic because they recognized the truth before they could say it out loud. The technique was outperforming established medicine, and worse, it was doing so consistently. That meant the problem wasn't execution. It was philosophy. The manuals assumed time was available. The battlefield proved it wasn't. This created a psychological crisis within military medicine. If aggressive early intervention was correct, then restraint had been costing lives. And admitting that meant confronting moral weight no institution wants to carry. It wasn't just. A technical error was a human one. So the system tried another tactic: silence. Cases were underreported. Language was adjusted. Survival was attributed to exceptional circumstances. Doctors were instructed not to publicize outcomes. The technique was neither approved nor banned. It was buried. The goal wasn't resolution. It was containment. Yet even containment failed because doctors talk. Surgeons compare outcomes, and nothing travels faster in war than information that saves lives. The technique spread organically, passed from one exhausted professional to another with the same quiet urgency. This works. Don't wait. And with each success, the pressure increased. The most painful moment for the establishment came when junior doctors, those lowest in the hierarchies, outperforming their mentors. Not because they were smarter, but because they were willing to act. That inversion of authority was intolerable. Expertise was supposed to flow downward, not upward. What followed was predictable. Formal resistance hardened. Warnings escalated. Careers were threatened, but the battlefield didn't care about reputations. It rewarded results, and the results were undeniable. By now, the forbidden technique wasn't a rumor. It was an open secret. The question was no longer whether it worked. The question was how long the system could pretend it didn't. When institutions feel threatened, they rarely admit uncertainty. They retaliate. As the forbidden technique continued to save lives, the response from the medical and military hierarchy turned openly hostile. What began as skepticism hardened into punishment. The system wasn't trying to understand the technique anymore, it was trying to erase it. Doctors who used it too openly were reassigned. Others were removed from surgical duties under vague justifications like risk management or disciplinary rotation. Some received formal warnings placed quietly in their files. No accusations were made publicly, but the message was unmistakable. Stop this, or your career ends here. Official memos began circulating, carefully worded but sharp in intent. They warned against unauthorized experimental procedures. They reminded staff of chain of command and medical liability. They emphasized adherence to protocol as a matter of discipline, not outcomes. The language avoided naming the technique directly, but everyone knew what it meant. Fear returned to the operating rooms. Not fear of failure, but fear of consequence. Surgeons now faced a brutal choice: follow the rules and watch patients die, knowing they could have acted sooner, or break protocol, save lives, and risk professional exile. For some, the pressure worked. They stopped using the technique. Mortality in those units climbed back to its previous levels almost immediately. Others refused. They continued quietly, selectively, using the technique only in the most desperate cases. They documented nothing. They spoke little. Survival became something to hide rather than celebrate. A successful outcome wasn't shared, it was buried to protect everyone involved. The military command structure added another layer of resistance. From their perspective, this wasn't just a medical issue. It was a control issue. If doctors could decide which rules mattered in surgery, what stopped soldiers from doing the same in combat? Discipline depended on predictability. The forbidden technique represented chaos, judgment replacing centralized authority, and chaos terrified them. So investigations were launched, not to evaluate effectiveness, but to locate sources. Who was teaching this? Where did it start? Could it be contained? Reports were compiled. Names were whispered. Some units were flagged as non-compliant. Ironically, these investigations produced an unintended effect. They confirmed the technique was widespread. The more leadership tried to suppress it, the more evidence emerged that it was already deeply embedded. Casualty reports from multiple fronts showed identical patterns. Units suspected of using the technique had markedly better survival rates. Suppression was no longer preventing spread, it was exposing it. This forced a strategic dilemma. Punishing every doctor involved would cripple medical capacity during active combat. Allowing the technique openly would undermine authority. The system chose a third option: delay, stall, avoid making a decision for as long as possible. But war does not pause for bureaucracy. As casualty numbers surged and evacuation chains collapsed under strain, commanders began prioritizing outcomes over ideology. Quiet instructions were issued. Do whatever keeps them alive. Not written, not official, but understood. The forbidden technique had reached a tipping point. It was no longer a rebellion by doctors. It was an adaptation forced by reality. The system had tried to crush it and failed. Now it had to live with it without admitting it existed. And that denial would only last until the war itself made the truth unavoidable. War has a brutal way of stripping away denial. As casualty numbers surged, the medical systems buckled. The gap between official doctrine and battlefield reality became impossible to ignore. Entire units were being overwhelmed. Evacuation routes were delayed or destroyed. Supplies ran thin. Time, the one thing traditional medicine assumed it had simply no longer existed. And that's when the war itself forced the truth into the open. Commanders began noticing a pattern they could no longer explain away. Certain medical units were returning more soldiers to duty. Others were sending fewer bodies to graves. The difference wasn't equipment. It wasn't location. It wasn't luck. It was speed and willingness to act decisively before collapse set in. At first, leadership tried to rationalize it. Maybe those units had better surgeons. Maybe the injuries were less severe. Maybe the reports were exaggerated. But the trend persisted. across fronts, across teams, across conditions. The only consistent variable was the technique everyone pretended didn't exist. This created a crisis of command. High-ranking officers were no longer asking if the forbidden method was being used. They were asking why survival rates dropped when it wasn't. And unlike medical administrators, battlefield commanders measured success in lives, not compliance. Quietly, priorities shifted. Orders changed tone. Not formally, not on paper, but in implication. Surgeons were told to use their judgment. Medical officers were advised to adapt to conditions. No one said the word technique, but the leash loosened. What had once been punished was now tolerated so long as it worked. The irony was brutal. The same system that had called the method madness now depended on it to function. Hospitals that resisted it collapsed under casualties. Those that embraced it silently kept operating. War didn't reward obedience. It rewarded effectiveness. Once this shift occurred, the transformation accelerated. Doctors began intervening earlier, faster, more decisively. Bleeding control became immediate. Shock was interrupted instead of managed passively. Surgical timelines compressed from hours to minutes. Mortality dropped in ways that even skeptics could not deny. But recognition still didn't come. There were no announcements, no revisions to manuals, no public reversals. Officially, nothing had changed. Unofficially, everything had. The forbidden technique became standard practice without ever being named as such. This created a strange historical blind spot. Future reports would show improved survival without explaining why. Medical doctrine appeared to evolve naturally, as if discoveries emerged cleanly through research rather than desperation. The truth that lives were saved by breaking rules long before those rules were rewritten was erased. Yet the doctors who lived through it knew. They remembered the resistance, the threats, the silence. They remembered colleagues punished for being right too early. And they remembered the patients who lived only because someone dared to act before permission was granted. The war forced the system's hand, but the system never admitted defeat, and that refusal to acknowledge the past would shape medicine long after the fighting ended. Once the war ended, the narrative quietly changed. Officially, medical progress was described as a smooth evolution, refinements in technique, gradual improvements in trauma care, lessons learned over time. What was never openly acknowledged was that many of those lessons had already been learned under fire, long before they were approved, documented, or taught. The forbidden technique didn't disappear after the fighting stopped. It was absorbed, but it was absorbed selectively, carefully, and without credit. In post-war medical reviews, new protocols began to appear that looked suspiciously familiar. Earlier intervention, faster surgical, aggressive control of bleeding before full stabilization, shock treated as an act of emergency rather than a condition to observe. On paper, these changes were framed as innovations. In reality, they were formalizations of what frontline doctors had been doing quietly for years. The language changed to make it acceptable. What was once called reckless became time-sensitive. What was once unsafe became decisive. What was once madness became best practice. But the origin story was there were no footnotes acknowledging the surgeons who broke protocol. No recognition of the doctors who risked their careers to save lives. No admission that institutional resistance had delayed progress while people died. History was rewritten to make advancement look orderly, controlled, and inevitable. This wasn't accidental. Institutions survive by preserving legitimacy. admitting that life-saving practices emerged despite authority rather than because of it would undermine trust. So the system chose amnesia. The results were kept. The rebellion that produced them was forgotten. Medical schools began teaching these revised protocols as if they had always existed. Young doctors learned them without ever knowing they were once forbidden, without knowing patients had died, while leaders debated whether innovation was acceptable, without knowing that hesitation, not ignorance, had been the true killer. And the pattern didn't stop there. The same resistance appeared again and again in later conflicts. New approaches to trauma care, emergency response, critical intervention. Each time, frontline practitioners adapted faster than institutions. Each time, results came first. Recognition came less stiff at all. What this revealed was deeply uncomfortable. Medicine didn't advance because it was open to change. It advanced because reality forced it to. Progress happened not through permission, but through pressure. Through failure becoming impossible to ignore, the forbidden technique became doctrine not because it was embraced, but because it couldn't be suppressed anymore. And that raises a disturbing question. If this life-saving knowledge was delayed once, how many times has it been delayed since? Before we go further, comment absorbed if you're starting to see how systems take credit for what they once tried to destroy. The official reports never captured the real number. On paper, the war ended with neat statistics, casualty totals, survival percentages, timelines of medical improvement. But buried beneath those numbers were thousands of individuals whose lives existed outside the narrative. Soldiers who survived not because the system worked, but because someone ignored it. These men never appeared in commendations or journals. Their cases weren't highlighted in lectures. Many of their doctors couldn't even document what had actually saved them without risking scrutiny. So, their survival became anonymous, folded quietly into averages that hid the truth. And averages are convenient. They blur cause and effect. They allow institutions to claim success without confronting how that success was achieved. A soldier who lived because a surgeon broke protocol looked identical on paper to one saved by standard procedure. The distinction critical, uncomfortable was erased, but on the ground, the difference was obvious. Doctors remembered faces. They remembered patients who would have been written off under traditional doctrine. Men who arrived pulseless, cold, nearly gone, walked out weeks later because someone acted early, decisively, against orders. Those survivors carried the legacy forward silently, never knowing they had been part of a forbidden chapter in medical history. Some of them returned to combat. Some went home. Some lived long lives, never realizing how close they had come to dying for the sake of procedure. The cost of suppression wasn't just delayed progress, it was invisible death. Every unit that resisted the technique lost patients who might have lived. Every week of delay meant more graves, more letters home, more unavoidable losses that were anything but unavoidable. But because those deaths followed protocol, they were never questioned. That's the most dangerous kind of failure. Not the one that breaks rules, but the one that follows them perfectly. What makes this harder to confront is that the system wasn't malicious. It was cautious, protective, convinced it was preventing harm. But intention doesn't change outcome. The result was the same. Innovation was punished, obedience was rewarded, and lives were lost in the gap. This pattern didn't end with that war. It repeated itself in later conflicts, in civilian emergency medicine, in disaster response. Techniques that challenged established timelines were resisted until reality forced acceptance. Again and again, progress arrived late after people paid the price. The thousands saved by the forbidden technique were never counted as such. They were absorbed into history without acknowledgement. Their survival didn't challenge doctrine because doctrine claimed them anyway. And that's why this story matters, not as a celebration of rebellion, but as a warning. Because when institutions refuse to acknowledge how progress truly happens, they guarantee the cycle will repeat. Even today, modern medicine struggles to speak honestly about how this transformation truly happened. Textbooks present clean conferences highlight innovation as a natural event. Protocols are framed as the result of careful research, peer review, and institutional wisdom. What's missing is the uncomfortable origin of period when lives were saved before approval existed, when progress happened in defiance of authority rather than under its guidance. That omission is not accidental. Modern systems depend on trust. Patients trust doctors. Doctors trust institutions. Institutions trust their own legitimacy, acknowledging that one of the most important shifts in trauma medicine came from rule-breaking under pressure, threatens that entire structure. It suggests that obedience is not always safety. That protocol can lag behind reality. That judgment in critical moments may matter more than permission. And that idea is dangerous. Because if medicine admits this once, it must admit it again. It must confront how often innovation is delayed by hierarchy, how frequently frontline professionals recognize truth long before committees do, how many lives are lost while institutions debate whether evidence is acceptable. So instead, the story is soft. Language is adjusted. Credit is redistributed. The forbidden becomes inevitable. The rebellion becomes refinement. And the doctors who acted first, the ones who risked careers, reputation, and punishment fade into obscurity. What remains is a sanitized version of progress. Beneath that surface, the pattern persists. In every generation, there are moments when established knowledge collides with reality. Moments when rules protect the system more than the people it serves. Moments when someone must choose between being correct and being compliant. The doctors who used the so-called madness technique didn't see themselves as heroes. They didn't see themselves as rebels. They saw dying patients and understood that waiting was worse than acting. Their legacy isn't just a medical advancement, it's a reminder that progress often arrives early, unwelcome, and mislabeled. And the most uncomfortable truth of all is this: if thousands were saved only after the system was forced to adapt, how many were lost before it did? That question still echoes in modern medicine, whether it's spoken or not. If you stayed until the end, you're someone who understands that history isn't just about what happened, it's about what was almost allowed to happen and what was delayed until it was too late. If this story changed the way you see medicine, authority, or innovation under pressure, leave a comment right now with the word madness so others know you made it to the end and understood the deeper message. Make sure to like this video if you believe uncomfortable truths deserve to be told, and subscribe to the channel so you don't miss the next story that history tried to clean up and forget. And before you go, click on the next video appearing on your screen now. It explores another moment when breaking the rules wasn't requisite, was the only reason anyone survived.